Good night. Welcome, everybody. Thanks again for being here. I really enjoyed this webinars. Thank you, Brightbot, for sponsoring this webinars. Um, I would like to say that throughout the webinar, everybody's microphone is going to be muted. But at the end of the presentation, I'm going to be answering some of the questions, which is my favorite part. Also, I would like to ask you that if you, by any reason, have any question at the end of the webinar or tomorrow, you can go into brightbot.com and record your question in a video, and somebody, either me or somebody else, will answer through a video response your questions. So let's begin. Also, I would like to remind you that this comes from my medical experience and does not replace like a medical consultation. This is just for give you certain guidance and certain information for you to know. We're going to be dealing today with the second part of my high blood pressure, the hypertension. This time, the last one I called the silent killer. This one's titled Knowing Your Enemy. Because I think it's very important that that we as patients and regular people, we have to know whatever we're dealing with so we can fight against it more effectively. For those of you who do not know me, my name is Jaime Mesa. I'm a doctor. I work mainly in the ER, but also in preventive medicine. And I enjoy all these subjects very much. In my past webinar, I talked about high blood pressure, and I gave certain numbers. I'm going to just repeat a few of them so we can like be in the same page. Remember that high blood pressure, 1 out of 3 people in the United States has high blood pressure, and one of those 3 out of those 3 who have it doesn't know he has it or she has it. And even when they know it, 1/3 of the hypertensive population, it's not controlled. That means their blood pressure is not on their goals. So this is something alarming, especially when you take into account that this is a condition that kills directly and indirectly 1,100 Americans a day, which is huge. In the other webinar, I talked a little bit more about what it is and certain other things. Here, I would like to give or answer certain questions that might rise and give you just little information of why we do certain things as we do it. And I think it's very valuable for the patients. The first is, how do we measure the blood pressure? And I know it might sound like a very simple question, but probably most of you do not know like the science behind it. So I'm gonna just briefly describe the most common method we use. Here in the image, you see that basically we have an inflatable cuff, which is very, very common. Probably you've seen it on your doctor's office, or probably you have one for yourself in your house. Basically, we inflate that cuff until the blood flow in the artery stops. That's why we use also a stethoscope, which is the device we put in our ears. Doctors and nurses use. That's why we have to use it, because we want to hear the artery. And I want you to know that normally, if you put the stethoscope in your chest, you're gonna listen to your heart, the heartbeat, like do 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 do. But if you put it on your arm, you're not gonna hear anything. People think that we can hear the blood flowing, but we can't actually. It's so quiet that it's not even with a stethoscope we can do it. So we inflate it until there's no more blood flow. How we know it for a normal person, blood stops flowing at 200 millimeters of mercury. Or if we want to be sure, we just take the pulse. So when we don't feel a pulse anymore, that means the cough needs to be, has reached the point where there's no more blood flow. Then we put the stethoscope and we start deflating the cuff until we hear certain sounds similar to the heartbeat. Those we can. Why? Because we start opening the artery so slowly that the blood flow, it's very, let's say, it's not linear, it's not flowing like a calm river, it's very disorganized. So we actually hear like the blood flowing. And then as we continue opening the cuff, deflating the cuff, we stop hearing any noise. So when we hear the first sound, that's the systolic, the high number, the first number we use. And when we stop hearing any noise, that's the second number we use. So that is something that might answer certain questions about why do we use a stethoscope and how is it that we do it. That's the way. Well, automatic machines, they have devices to detect that sound, so that's why they don't use it, but this is the most reliable way of doing it. Another thing that I mentioned in the past webinar, but I need to explain a little further, is what is the normal value for blood pressure in adults. And this is because for children, that's something totally different. But in adults, I did mention that it was 120/80 millimeters of mercury. There are other values that you might even hear from your doctor or read, which are, for example, 140/90. And that is, I have to explain why we use that number. First of all, as you see, I have the check mark, the green check mark in 120/80, because that is the normal blood pressure. That is the highest you should have it, no matter if you're 18 or 50. But we've discovered that all of us will start, our blood pressures will start rising with age. So we have put some other values that are acceptable, and I'm going to explain that. If you are diabetic, you have chronic kidney disease, and you are under 60, we start treating high blood pressure with the value of 140/90 millimeters of mercury. But that doesn't mean that if you have, that doesn't mean that 140/90 it's normal. That means we are just gonna start medications in that value, but normal is still 120/80. And if you are 60 or older, we start medications for, when you have 150/90. Again, that doesn't mean 150/90 it's the normal. It just means that we start medications at that time. So you might ask, what if I am 60 and I have 140/90? Well, if you're 60, you should be 120/80 as everyone else, but you have not reached the blood pressure that we start medications. So that means you should start reducing your salt intake, your sodium intake, increasing your potassium intake, doing exercise more regularly, and then we'll see if those strategies work. And if you reach the 100/50, we're gonna start medications on you. But the normal, it's always gonna be 120/80. And I want to explain this because a lot of patients, since they're not getting treatment because they have 140/90, they think that's the normal, but it's not. It's always 120/80. That's what it should be. If you have a value that's higher than that, you should start taking action. Not necessarily medication. Of course, you have to go to your doctor, but you have to start changing your lifestyle. I didn't have enough time last time, and to explain what happens actually when you do not control high blood pressure in a right way. Well, as I explained last time, having high blood pressure is like having a lot of water running through the pipes of your house. Sooner or later, bad things are going to happen. But there are two things that might happen: either something acute like an emergency right now, or some damage that is going to be done throughout time. So let's talk about that first, like chronic damage. Arteries are elastic. They are very good at receiving lots of blood, and they simply stretch to receive that amount of blood, and they just go back to their normal size. But if they are under a lot of pressure for a long time, they, like any other muscle, they will start growing and reacting to that high blood pressure. So they become more muscular and they start narrowing. So the number one consequence of high blood pressure is the narrowing of the arteries. So as you can see there a healthy artery versus one that's narrowed and one that's severely narrowed. And you can imagine what can happen. But if you want certain examples and a further explanation, I'm gonna give it to you right away. One of the things that happens when your artery is narrow is that blood stops getting to the right places. So you can develop something that is called peripheral arterial disease. And you can see there the picture. There's this man who has pain on his left calf, sorry. So that's the symptoms you should be looking for to see if you're developing peripheral artery disease. What's the best example? Somebody that's walking and a certain distance, for everyone is different, maybe 100 yards, 200 yards, maybe more. They start feeling certain pain on their legs. And it gets worse until they have to stop. And when they stop, the pain actually gets better and they're able to walk again. So if they wait for a long time, they will feel like nothing happened. They will start walking again, and again, the same 200, 300 yards, the pain is gonna come back. So that's a sign that your arteries in your legs are narrowing. And this process can even be worsened by fat in your arteries, cholesterol. So getting those two things together, high cholesterol and high blood pressure, might actually increase your risk. So that's one of the things that could happen and happen to the people with high blood pressure. The second one is that if this happens in your legs, it's going to happen somewhere else. The kidney is also very common. It's a very, what we call a target organ for the high blood pressure. So when the arteries in the kidney narrow, the blood flow decreases and urine is produced by filtering blood. Basically, blood flows through the kidney filters it, takes out the water, salt, and some things, and you urinate that excess of water. But if there's no enough blood flow, then that water, that excess fluid, is gonna accumulate in your body, and that's what we call retaining fluids. And you're gonna start having edema, swollen legs at first. So you should maybe take a look at yourself, and maybe you see that your ankles are a little bit more swollen than normal. Maybe it's because you have high blood pressure and it's not controlled. There are some other causes for that, but this is one that you should definitely take a look. And it's very, very common. I'm pretty sure probably one or more of the people that's listening might have noticed this. Well, the heart is the center of the circulatory system. It's a pump, it's a muscle, it's the biggest and hardest, strongest muscle in the body. But of course, like everyone, it gets tired and it has changes with high blood pressure. If they have, when the arteries narrow, just imagine that you have the garden hose of your house and you narrow the hose. Water would flow very, very, very fast, and it will try to uh, like take water back or reverse the flow of water. So this heart, the pump, has to make more effort to make the blood flow through a tube that is now narrower. So of course, the reaction of every muscle when they have to do more effort, they grow. So the heart starts growing. But you know, the heart is not perfect. So eventually it will grow that much that it simply will be too big to carry its own weight. And not only that, the walls eventually, after growing, at first it grows strong like every muscle, but then it will simply uh, become weaker and weaker until you get something that is called heart failure. And you maybe have heard about that term, like, oh, he has congestive heart failure. Well, that's it, congestive. It has so much blood that that he cannot pump out, that he gets congested, choked on his own blood. That's what happens, and it starts reversing the flow, so it goes back to your lungs and you start having breathing issues. That is something you should also look for. If you're starting to have shortness of breath, maybe this is the cause of that. Another thing that happens, as I'm telling you, the blood doesn't flow as easy as it used to. So the main vessels, the main arteries in the body, have to sustain a lot of pressure. The main artery in the body is the aorta, which you see there in the image, and it starts growing and growing into what we call a aneurysm. And eventually, aneurysms are like a time bomb. I mean, arteries keep growing and growing and enlarging that aneurysm until it finally breaks. And the aorta carries 5 to 6 liters of blood every minute. So that's the entire quantity, or the entire amount of blood you have in your body. It passes through that artery each minute. So if it breaks, you have 30 seconds. So that's something we should take a look. That's why it is part of your screening things, like we have to do colon screening, you know, prostate, cervical cancer, breast cancer, and also we have to check for abdominal aneurysms, for the abdominal aorta. That's through an ultrasound. They just put it on your abdomen and they see the size of the aorta. Doesn't have any much symptoms, but usually it's not really painful, but it manifests with a pulsating mass in your abdomen. So that can happen. Maybe if you're there and you see that your abdomen, it's beating like a heart, that's what happens. Of course, with thin people, if you're thin, you'll be able to feel your aorta, like the blood flowing through it, so that's normal. But especially if you're older than 60 and you have like a big mass in your abdomen that's pulsating, you should get it checked. Dementia. That's another consequence of high blood pressure, and I don't see a lot of people talking about it. We do talk about dementias and Alzheimer's, which is one type of the dementia, but no one usually talks about vascular dementia, which is very similar to Alzheimer's or can be mixed up with Alzheimer's. But that's a good consequence. People think, well, maybe I didn't have a heart attack or a stroke, or my kidneys are well, so blood pressure is not doing anything to me. Well, wait, because maybe when you're 60, 65 or older, you will start developing signs of dementia, which can be disorientation in time. You don't know what time is it, what day is it. You stop recognizing people. Well, things like that. Actually, I'm going to be talking about certain dementias in my next webinar, but that's for another day. And also the losing of certain of your vision, blindness. High blood pressure doesn't doesn't leave you blind from one day to the other, not normally. It's something that's chronic. It takes time because basically you start having little hemorrhages in your retina, the back part of your eye, and you start losing certain fields of your vision. Like in this picture, you see that certain parts of the picture you can actually see pretty well, and in the center it's kind of blurry. That doesn't necessarily happen in the center all the time, but you start losing certain fields of vision, we call it. In the last webinar, I also talked about something that is called the DASH diet, and somebody asked me about it, so I wanted to give a little more explanation. So DASH means dietary approach to stop hypertension. That it's something that nutritionists and doctors have developed, especially for hypertension. We've discovered that it's great for losing weight also, but this is specific for high blood pressure. So in this diet, this is just an example because the actual diet has a lot of pages because it gives you a lot of options. But you will see and you will notice that this diet is somehow different from regular losing weight diets because it lets you eat certain things that you're not allowed to eat with other diets. Like, for example, bread and cereal and rice, and it actually has big portions of that. It tells you, depending on how many calories are you consuming each day, it tells you how many servings of each of the food group you can have. So if you're like a regular person, you're in a 2,000 calories a day. That means you can have 6 to 8 servings per day of grains, 4 to 5 of vegetables, 4 to 5 of fruits, and of course you'll see that certain things you'll have to well, reduce in the day. But I encourage if you're hypertensive to go and just write DASH diet, and you'll be able to print a lot of information about it, and it will help you a lot. This is just to explain a little bit more what I talked about. These are our foods that are low on sodium, high on potassium, and that limit the amount of fat and sometimes water, because that's another thing that we do not realize, is that for hypertensive patients, it's not very good to drink a lot of water, because water gets absorbed by the stomach and the colon, and it becomes blood. So if you put more blood to a hypertensive patient, you're gonna actually rise his blood pressure. So limiting the amounts of liquid, it's also an approach for high blood pressure. That's why actually we give water pills, diuretics for controlling that. That doesn't mean you're supposed to stop drinking water or liquids, no, but just limiting to a certain amount. Now, something that's very, very, very important. When it's an emergency, you should go to the emergency room if you feel you're having a stroke, you have chest pain, you have difficulty breathing, you stop urinating blood, or if you lost your vision. Those 5 things are definitely go to the emergency room. If they happen, like headaches, loss of vision, impaired movement, impaired speech, you should definitely go to the ER. I hope you liked it, and please let's go on with the questions. I enjoy that.
Dr. Mesa, I have a question about water, because that's my drug of choice.
You have a question about what? Sorry?
Water.
Oh, water.
Yeah, that's my drug of choice. I'm using water. I am not a soda drinker. Don't use coffee or anything like that. So if I don't use water, it's like I can't survive. First thing in the morning, last thing at night, all during the day.
Well, water, it's very important. I mean, the body needs water all the time. So by no means I'm telling you that you shouldn't. But if you have high blood pressure, you should definitely, if it's not controlled, you should definitely see if maybe you're taking too much water. How much water would be too much? Sometimes we limit the intake of water to about 2 liters per day. And sometimes even more, like 1.5 liters per day. But if you have high blood pressure and it's controlled, and you're taking the blood pressure regularly, like 2 or 3 times a day, and it's normal, then you can drink as much water as you're taking right now. It doesn't have any problems.
Because at one point in time, even with my daughter, and she's an adult now, they had told her that she was using too much water. But she was an athlete, raised her, just using a lot of water rather than sodas or anything like that.
Well, that was bad. That could be bad also, not because of the high blood pressure, but because for athletes, when they sweat, they lose a lot of electrolytes like sodium, potassium, chloride, and some other electrolytes. And if they keep drinking water, they will just replace water, but not the electrolytes. So that means it's going to dilute the blood. So they will suffer certain consequences of that. So they should use like Gatorade or some similar hydration fluids. But that's a totally different reason from the high blood pressure.
Oh, okay. All right. Thanks.
You're welcome.
Dr. Jamie, it's only in the frontal lobe you're diagnosed as having a stroke?
No, not at all. Not at all. It can happen in different lobes. The most common, it's the temporal lobe actually, and because usually it depends on the artery. We have to remember that a stroke happens when one of two things happen: when an artery gets clogged, or when it breaks and you start bleeding. The most common artery, it's called the the medial cerebral artery, which goes to the temporal lobe. So that's that part of the brain controls speech and movement, and that's why most people who suffer strokes will get paralyzed from half of their body, and some of them will have impaired speech. There are some other different strokes in the frontal lobe, occipital lobe, that cause other types of symptoms, but the most common is there, as I said, but it can occur in different lobes.
Okay.
Dr. Jamie.
Yes.
Yes. You said, going back to the numbers for the hypertension, 60 or older. Okay, you said it's supposed to be 150 over 90. What happens? Okay, you said if you're less than 60, it's what, it could be 140 over 90, right? If you're less than 60. So what happens when you get older, like when you pass 65? Now, let's say you're taking exercises and you're watching what you eat and that kind. Is it a given that can it stay where it should be, or does it, because of the age, it automatically goes to the next level?
I didn't understand the questions that I couldn't hear very clearly. Can you repeat it? Sorry.
Okay, under 60, you said it should be 140 over 90, right?
Yes.
And then as you get older, it will go to 150 over 90. I'm saying that when you're under 60, if you take all the precautions, you exercise, you do all you need to, will it stay within that range, or it will automatically go to a higher range because you're older?
Well, usually as we get older, blood pressure rises, not to everyone, but yes, to the most patients. I mean, most of the patients will increase the level of their blood pressure. It's not necessarily that if you get older, you are going to have high blood pressure, or that at least the value is gonna increase. If you do exercise and you have a good diet, it helps. It does not guarantee that you're not gonna have it, because it has a good genetical part that's in there. But that's actually something new. Actually, these numbers that I'm telling you, there's something about last year and this year. In the previous guidelines, we were treating everyone 140 over 90. Now we learned that it's normal for certain people to have that blood pressure without being actually a disease, but being normal. So some people will get there and some others will not. Just that number is for us doctors and you patients to know when we should start treatment, but does not necessarily mean all of people are gonna have that level of blood pressure.
Okay, thank you.
Okay, you're welcome.
Dr. Jamie, got a couple of questions, sir.
Okay.
First one is, if somebody who's restricting their water intake, right? Would you recommend that they eat like fruit to keep themselves hydrated, or would that be kind of negligible benefit?
Well, water is water, no matter where it comes from. So when we restrict fluids, we restrict them from solids and liquids. So if you have to, let's say you are hypertensive and you see that your blood pressure is uncontrolled because you might be taking extra fluids, extra water, and your doctor says you should restrict to certain quantity. That would be not only in fluids, but also in fruits. So it's not good if you just take, let's say 1.5 liters of water and you make up for that having a lot of watermelons because you want to be hydrated. That's also going to be water, so it's going to remain the same. But I do think that if you are going to restrain your fluids, you should mix them between liquids and fruits and vegetables, because you will gain something extra that is not only the water, but electrolytes and potassium, especially in some fruits and vegetables. So I would recommend that.
Okay, thank you. My other question is, whenever you hear healthcare professionals talk about hypertension, a lot of times they'll say hypertension and diabetes, and it seemed like they almost link the two, a lot when they're talking about it. Now, is that because of the restricted blood flow that they both cause, or is there some other?
Well, there's a relation between diabetes and high blood pressure that is stronger than the relation of high blood pressure to diabetes. Why? Because probably if you have a problem with your arteries. It will not cause a problem with your pancreas. I mean, high blood pressure will not cause diabetes, but diabetes might affect your arteries and the muscle around it, so they will not be as flexible as they used to be. So you might actually get high blood pressure from diabetes, or at least it might trigger it faster or worsen it. Okay.
Okay, another question, Dr. Jamie. The pain that you get in your leg from the peripheral artery disease, is that similar to like a muscle contract? Is that what we're talking about?
No.
The difference in?
Artery disease is like all the muscles need oxygen, need nutrients, and those nutrients come in the blood. So they have to have healthy arteries for the muscles to work. When they start narrowing, the blood flow decreases, and then you will start feeling pain, like cramps. It's similar to the chest pain, where you don't have enough blood in your heart, it will hurt, the same as in the muscles of your legs. If they don't receive enough blood, they're going to start hurting. That's basically the explanation.
No, so there is a difference between that and a muscle contract.
Yeah.
What we call muscle contract, which
yes.
you would get in your leg.
Yeah, it might feel similar, but in a muscle contract, when the muscle contracts, you will actually feel like it's contracting. In this case, the feeling might be similar, but the muscle will be totally relaxed.
Okay, I see. All right, thank you.
You're welcome.
Dr. Jamie, sometimes when I'm walking, I don't get muscle cramps, but I get this pain in my right butt. Does that have anything to do with your arteries? No?
It might be. It might be. It's not very, it's not the most common symptom of peripheral artery disease, because usually what gets affected are the things that are farthest from the heart, like toes, and then your calves, and then your thighs, and last your buttocks. But it might be. Probably you are either experiencing some muscular pain from the muscles that are around the hip. That might be a good explanation. But of course, we will have to examine you and run some tests for me to know exactly. I wouldn't say it's the most common symptom of that. It could be, but I don't think it's because of that.
Okay, thank you.
Okay.
Dr. Jamie, with
Yes.
someone with a blood pressure of, say, 130/70, where would that fall
Oh,
in your
okay.
reading?
130/70. That is definitely above 120/80, because one of the two numbers exceeded. So the 130 exceeded the 120. That means he definitely has something. But since he has not overpassed the 140, that means he's in between. That means he's pre-hypertensive. That's the term we use. So that means he's not ready for medications, but he has to make certain changes: diet, exercise, and continuous observation.
Okay. Thank you.
You're welcome.
There's another question, Dr. Jamie. Does weight gain has anything to do with your blood pressure?
Weight gain, definitely. When people gain weight, there's more mass in your body, more tissue. That means there has to be more blood flow, and it might actually increase your blood pressure. Some people, just by losing weight, they are able to control their blood pressure. So actually, for example, the example you gave, somebody with 130/70, that probably is overweight. If he loses 10 or 20 pounds, he might be returning to a normal blood pressure just by losing weight.
Thank you.
You're welcome. Okay.
I have a couple questions, actually.
Oh, go ahead, Joe.
Thank you. First, I saw you had a picture of an aneurysm. I don't know if it would be possible to go back to your slides, because my other question has to do with your slides also. But specifically with an aneurysm, I wasn't really sure how that would related to high blood pressure. Are you saying? Can you reiterate, please, how that's affected by high blood pressure?
Yes. Basically, arteries are like a garden hose. There's water flowing, and if you simply increase the pressure, let's say you open the faucet, the water flow, uh, that artery, will simply start to enlarge, like you see in the cartoons when somebody steps on the hose, the fire hose, it simply starts enlarging until it suddenly pops. That's exactly what happens in the arteries. It will start like bulging or being like a balloon, because it has a lot of pressure inside, a lot of blood flowing at a very high pressure until it suddenly explodes. Basically, that's what happens.
So, is it possible to detect an aneurysm while it's happening? And if it is possible, how can someone be able to differentiate between a migraine headache, which also feels like a lot of pressure, and an aneurysm?
Sometimes it's very difficult. Well, that's something that, yes, actually I need to clarify. This is just an example of the aneurysms, because of course you can have them in the brain, as you are mentioning now. This is just one case. It depends on the place the aneurysm is located in the brain, that may cause different symptoms. Sometimes it is very similar actually to a migraine. Sometimes it's to another type of headache. Unfortunately, it manifests to a point that we are able to diagnose it when it simply bursts. That's the bad news about it. Usually, that's how we find out. Usually, it doesn't have any symptom until it bursts. So, depending on the place it was located, it's basically going to be similar to a stroke. It's actually going to be a stroke. We might be able to find it without it having to burst, but usually are what we call incidental findings, that we were looking for something else and we found an artery that had an aneurysm. But it's impossible to know like a regular headache from an aneurysm. Of course, in the webinar, I talked about the emergency room. I said certain things about headaches that you should see. For example, having the worst headache of your life, having a headache that is usually different from the headaches you always have. For example, I have migraine and it's always in the right side of my head, and suddenly I have it on my left. That's something that should tell you that something might be wrong. Or simply having vision changes, changes in the way you speak or move, things like that.
Just one more question. If you wouldn't mind going to the last slide where you talk about the 5 different cases someone should go to the emergency room. There it is, yeah. Yeah. Okay, so my question is, I'll let you populate the slide. Yeah, so in this case we have, pressure in the head, or we have, heart pain or difficulty breathing, you were saying. And then I guess those are kidneys, so problem producing urine or problem eliminating urine. And then the 5th, I don't see what the 5th is. What is the 5th?
The 5th is the picture of an eye that's actually sectioned in the middle. So impaired vision, that's something.
Okay.
And I forgot to say, actually, in the right corner, you see the value of the blood pressure. That means 160 over 100 or greater than that, it's an emergency. Okay. And if it's, especially when it is together with any of the symptoms, but just 160 over 100 is an emergency. But
okay, so just my follow-up, I'm sorry if I interrupted you, but my follow-up is that, here we see 5 different things that could go wrong with our body. And then you mentioned the arterial problem where somebody is having a pain in his lower leg, and that could be the result of high blood pressure. And then there are aneurysms that could happen all over the body. So really, there's so many things that it would seem are related to high blood pressure. How could anyone possibly begin to diagnose themselves if they have high blood pressure? I'll leave it at that.
Well, it's very, remember, it's the silent killer. Usually you will not be able to feel anything or to actually get a warning. But you should monitor your blood pressure. That's number one. Even if you don't think you have it, like you're a normal person, you don't feel anything, it's always good to have your blood pressure monitored when you're going to the pharmacy, when you're going to the doctor. It's always good to know. And also, it would be good to look for those little details I mentioned before, like the pain, like the swelling on your legs, on your ankles, or maybe you're not seeing as well as you used to, or you see that you usually go to the bathroom and you pee 3 times a day, and you notice that in the last year that's been decreasing. Those are little things that might actually tell you, but it's impossible to diagnose yourself only by symptoms, because usually it's very silent and only the blood pressure reading will tell us that you have it.
Thank you.
Okay, thanks everybody for being here. I love the questions as always. Remember, if something comes up after this or you want to ask another question, just go into brightbud.com and record a video question, and we'll be able to answer it to you. And next week I'm going to be talking about Alzheimer's, which is very interesting also. I wait for you there. Have a good night.